Hi, I have Deshaun Waters as an ICU consult. He's a 64-year-old male who is 2 hours post transverse partial colectomy for stage 2 colon cancer. We were called for escalating abdominal pain in the PACU with concerning vital signs pertinent for hypotension. The patient underwent surgery today and initially reported abdominal pain despite initiation of pain management. The patient reports that the pain has continued over the last 20 minutes. It is currently a sharp stabbing pain that's constant in the upper abdomen, described at a 7 or 8 out of 10. The patient presented initially to the hospital for 4-month history of blood and stool, alternating diarrhea and constipation, unintentional weight loss of 15 pounds. His past surgical history includes appendectomy at age 6. His medical history is significant for hypertension and diabetes. The patient has never received blood transfusions in the past. On review of systems, he was positive for cold extremities, hand and feet, and cold intolerance, unable to get warm. He was positive for dry mouth, negative for mouth sores or any oral bleeding. He was positive for intermittent nausea, negative for blood and stool, and positive for abdominal pain, vomiting, and bloating. Negative for tingling or numbness in the extremities associated with the cold feeling, and negative for anxiety, depression, or sleep issues. All other uncommented systems are negative. His vital signs are 36.5 degrees Celsius temperature, tachycardic at 118 beats per minute, respiratory rate of 32. His blood pressure is on the soft side at 94/54, and his oxygen saturation is 90% on room air, initially with deterioration requiring intubation for airway protection and acute hypoxemic respiratory failure. On exam, he was alert and oriented ×4. He is now intubated and sedated. No head imaging was done. He had clear breath sounds that were equal bilaterally with increased work of breathing, shallow, rapid respirations. S1 and S2 were auscultated with no extra heart sounds. He is tachycardic on the monitor. Abdomen was tender to palpation in all 4 quadrants. Bowel sounds were active and present, and there's a Foley catheter in place making urine. Differentials considered were acute hemorrhage, acute hypoxemic respiratory failure, and severe abdominal pain. For his hemorrhage, we typed and crossed him. He is going to get 2 units of packed red cells initially for acute bleeding and the hemodynamic instability. We're going to monitor him closely hemodynamically, repeat hemoglobin and hematocrit every 4 hours, and we have reached out to surgery for reevaluation for the possible need of return to the OR for bleeding source control. For his acute hypoxemic respiratory failure, he was intubated and is on mechanical ventilation. Initial settings, volume control, rate of 20, 6 cc's per kg, ideal body weight, a PEEP of 8 and 100%. We are still pending a 30-minute post-intubation blood gas, and ventilator changes will be as indicated from the gas. We're going to wean oxygen as able to a goal SpO2 of 90%, sedation and analgesia with propofol and fentanyl, titrating to a RAS of -1 to -2 and a CPOT less than 3. We will SAT and SBT in the morning if hemodynamic concerns have resolved and there is no more bleeding. We want to monitor the CAM-ICU every 12 hours, and if he is following commands in the morning and not able to extubate, we will work with PTOT and initiate early mobility. For his abdominal pain, the etiology is most likely acute abdomen pathology. We have the fentanyl infusion as previously stated. We will use a multimodal pain regimen with acetaminophen and methocarbamol when surgery clears for PO, and non-pharmacological interventions include heating packs and positioning. The patient is full code and will be monitored with SCDs only for VTE prophylaxis, and PPI will be initiated for GI prophylaxis on the ventilator. Thank you.